Hi everyone, I'm Patricia Ding, cardiologist, and this is Dr. Hitesh Patel, cardiologist from Ascot Cardiology. Good afternoon, Hitesh.
Good afternoon, Patricia.
Right, so today our topic is on CTCA and calcium scoring, and this part of the session we're discussing using CTCA instead of calcium score as a screening tool to detect coronary artery disease. So does CTCA actually improve clinical outcome in asymptomatic patients?
Yeah, well, I guess, that is the $6 million question.
Well, personally, clinically, I use CTCA to perform on patients. They do have ambivalent or equivocal symptoms, equivocal ETTs, but perceived to have low to intermediate risk to rule out coronary artery disease, not to diagnose coronary artery disease.
A CT coronary angiography, a superior test in asymptomatic individuals compared to coronary artery calcium scoring, since it can detect high-risk plaque. The other question we'll address is whether CT angiography is a superior test because it can detect coronary artery stenosis. Let us look at the Factor 64 randomized trial that enrolled high-risk diabetics. We can see that 8% of the CTCA group went on to invasive angiography as a direct result of the findings of the CTCA, and around 4% got PCI and just over 1% got bypass surgery. During the course of the trial, patients also had symptom-driven PCI and CABG, but the CTCA group overall had more intervention at the end of the trial. But there was no difference in the composite outcome of all-cause mortality, non-fatal MI, or unstable angina requiring hospitalization. Next, we can look at the PROMISE trial. These patients actually did have chest pain, but the prevalence of obstructive disease was less than 10%. These chest pain patients were randomized to functional testing, which is what we do routinely, or to have routine CTCA. Not surprisingly, if you did more CTCA, you ended up doing more invasive angiograms at 90 days. And of course, the CTCA group were found to have more stenosis. They had more intervention. At 90 days, 6% in the CTCA group had intervention compared to 3% in the functional testing group. Some of this intervention included bypass surgery. But after 25 months, there was no difference in the composite primary endpoint. Once again, people might have raised the question of statistical power to detect an important difference. But now we have the ischemia trial. Before we did have the courage trial, and the ischemia trial showed there was no difference between early intervention compared to initial medical therapy, crossing over to intervention if necessary. You've already discussed this trial with Dr. Glennie, and I shall not talk much more about it, except that I'm keenly awaiting a publication from the ischemia trial that we would think must come at some stage. We want to know whether adverse plaque characteristics makes a difference in terms of response to initial medical therapy or initial invasive therapy. Now, what about the detection of high-risk plaque? Is this important? Let me show you the slide. Those who had two feature-positive plaques had a lower event-free survival. This was a patient-specific study, so this refers to the outcome of the patients, not necessarily the outcome of the plaque. The most important question, of course, is what is the absolute risk for each individual plaque?
Can you tell us what is a high-risk plaque?
Let us look at these histological slides. The first column shows you lesions that are just mildly stenotic. The last column are lesions that have severe stenosis. The bottom row is a slide of stable plaque. Even the bottom right image shows you a stable plaque, even though there is severe stenosis. The middle row are images of high-risk plaque, or what's referred to as thin cap fibroatheroma. Cap is thin and there is a necrotic core. So what are CT features that might indicate the presence of a high-risk plaque? Image A is that of a plaque with very mild stenosis, but there is a lot of surrounding soft plaque, and we refer to this as positive remodeling. In image B, the arrow points to a stenosis, but with a dark black region. We refer to this as low attenuation, and this is the CT appearance of a lipid-rich plaque. Image D displays a vessel in short axis. This appearance is called the napkin ring sign. The contrast-filled lumen has an area of low attenuation next to it, and surrounding this there is slightly denser plaque. We just don't know from CT scan appearances whether the fibrous cap is thin or thick. There has been a change of terminology from high-risk plaque to adverse risk plaque features to avoid giving the impression that all of these plaques are a ticking time bomb. In Scott Hart, those with adverse plaque and with obstructive disease did have a worse outcome, not surprisingly. What we are interested in today relates to the coronary artery calcium score. What they found is that even those with adverse plaques, the outcome was actually predicted by the coronary artery calcium score if this score was more than 100. Those with a calcium score less than 100, the presence of adverse plaque did increase risk. We really want to know how much this finding changed the area under the curve of the ROC. But this finding does not surprise us. Even those with nil calcium score can develop calcium within a few years. Logically, we might think that those individuals that have an initial nil calcium score who then develop calcium within a short time must have had soft plaque when their calcium score was nil. I do not know if we can state that all individuals with a calcium score less than 100 should now have CT coronary angiography to look for adverse plaque features. In this analysis from the large CONFIRM registry, they also found that once we take into account risk factors and the coronary artery calcium score, other features of the CT coronary angiogram did not add to the prognosis. This next slide just has information that also helps us keep the finding of adverse plaque in perspective. For example, in the Scott Hart study, 1,376 adverse plaques were present, and yet only 41 patients had an MI after 4.7 years. There's no doubt CT coronary angiography does give additional information and can identify adverse plaque features. We have not yet closed the chapter on the value of detection of adverse plaques yet, but I'm not sure we're justified in arranging CT coronary angiography routinely instead of coronary artery calcium scoring at this time.
They should still, so in everyday practice, they should still focus on general conventional risk factor treatment and prevention, shared decision making with patients, and I think for further invasive testing is mostly strongly guided by their clinical symptoms and then functional stress tests.